Good evening, everybody.
I'm very lucky to have 4 experts, and I would like to thank to Emilio, which is who is the president of the Recurrent Shoulder Society. Thank you to take 1 hour with us. I would like to thank you, Eiji from Japan, and he's very early. It's
Hi.
5 o'clock. Thank you, Eiji. And of course, Laurent is a good friend. His auntie, the same hour, is 9 o'clock, and he's very nice. And Marcus Schobel will arrive. He's on the fly from Zurich to Munich, and he will arrive. Of course, now we talk about anterior instability, and we will present with Jean-David Bertel 3 cases. And the concept is I show you the case, and after you have 8 questions, and the attendees can vote. And after I ask to each expert the treatment of the strategies that they use in this context. So I will start with recurrent anterior dislocation. I will share my screen. This is the first case. This is a woman, 36 years old. This is the right side. She doesn't do any competition. And the first dislocation was in 2014. It was an anterior dislocation. After the first trauma, there is 5 recurrent anterior dislocation. There is no hyperlaxity, no pain, but there is a big apprehension test, positive, and the gadget test is positive. So you see there is a complete mobility in forward elevation and external rotation. There is no pain. The function is 50%, and the EASY score is 2 per 10. So you can see the X-rays. There is a little abrasion of the glenoid anteriorly and a small heel sacs. And we have to do a CT scan. And for example, the CT scan, you can see the CT scan. You have a heel sacs lesion. You see that, a big heel sacs lesion. And you have no anterior erosion. So we did a CT scan with 3D reconstruction, and you can see the posterior heel sacs, and we measure the on track and off track, and the EG knows very well that because he described this technique. And for this patient, it was on track. So my question is for the attendees, what do you propose? Do you propose physiotherapy, Bankart remplissage, Latarjet, bone graft and remplissage? You have 1 minute to vote for the attendees. And now I would like to share, and this is a question for the expert now. Maybe Emilio, if I summarize, 36 years old, 5 recurrent anterior dislocation, leisure woman, big apprehension, heel sac lesions, little glenoid lesion, on track. What do you propose? Emilio.
Well, this is a quite controversial case because she's not so young lady. She's 36. She's not very active. But in spite of being on track, she has a quite large heel sac lesions and a small bony Bankart. So according to the way I think, this lady could be treated with a soft tissue procedure, just a Bankart procedure without a Remplissage. But following the images, I couldn't see clearly the axial view of the CT scan, but I don't know what AJ thinks, but probably this case should be off track. So if the lady is on track, I would treat her with a soft tissue procedure, but if in doubt, I would do a Latarjet.
Okay, but we measure the on track, and I respect the recommendation of AG, and I think that the size of the heel sacs is less than 85% D less small d. And I think that there is a difference of 3 millimeters, but I agree with you, it depends of your measurement, but I think this is on track. And during the operation, I test in abduction, there is no engaging lesion. There is no engaging lesion. AG, what do you think about this case?
Well, this case is a recurrent dislocation case, so I don't think physical therapy would work. If it is a first-time dislocation, then I think I would try physiotherapy. But in this case, she already had 5 recurrent dislocations, so no physiotherapy. And in this case, as you said, it's an on-track lesion. But my question is, there is a bony Bankert lesion at the anterior rim of the glenoid. When you measure the glenoid tract, did you include the bony fragment or not?
No, I respect your recommendation. I don't. I put the diameter, big D, and I don't miss little d regarding body Bankert. It's not D, it's D less bony Bankert.
Okay, so you did not include the bony fragment.
Yes.
Okay,
yes.
I understand. So, when we do this, I prefer to do the soft tissue repair, including this bony fragment. So it's a bony Bankert repair without any remplissage or anything like that, because this case is already on track. So if you repair the bony fragment, the width of the glenoid will be even bigger eventually. So I think it's, for me, totally okay to do the bony Bankert repair alone. That's my opinion.
The controversy in these cases, to me, my practice, is that sometimes they're difficult to measure, because when you have a combined bipolar defect, sometimes it's difficult to measure what the glenoid tract is. Because you need to make sure that the small bony fragment is excluded from the measurement. And in this case, if the lesion is on track as measured, probably a repair, soft tissue repair, including the bony defect, could be good enough to restoring instability, considering the age or the physical activity of the patient.
Okay, she's not very active. She's 36 years old. She does laser, but without any throwing. Is not a throwing athlete. You see that? The big problem for her is the apprehension. And when she does abduction and she has apprehension, and this is a problem during daily life, not only for the sports. Do you have we can discuss, we have a little time, about the indication of remplissage. I am agree with you regarding soft tissue procedure, but when you decide to do remplissage, when you do a Bankert procedure, AG.
Well, if the lesion is an off-track lesion and the glenoid defect is small, then I prefer to do a Bankert repair plus remplissage. Okay. But these days, remplissage, sometimes people complain pain after the surgery. And I don't know, in the long run, like 20, 30, 40 years later, the patient may have infraspinatus tear. That's my concern. So I prefer to do Latarjet rather than remplissage.
Okay. And Emilio, what do you think?
It's very interesting what AG said about the potential future lesion of the infraspinatus in patients with remplissage. I can tell you, I'm not a big supporter of remplissage, so whenever I have a patient with an off-track heel sac lesions, I prefer to do a Latarjet. And we have recently analyzed the ability of a Latarjet to restore the glenoid tract, and it can be very efficient in restoring glenoid tract, but there is still a very small subpopulation of patients where the Latarjet is not good enough in restoring the glenoid tract. These are cases with large, very large heel sacs and bony banker lesions. And this could be to me the only indications to add a Remplissage to a Latarjet. But this is very, very uncommon. In the majority of cases, the off-track lesions can turn into on-track with the Latarjet, and I don't need to do any Remplissage procedure.
Okay, maybe Laurent, you can comment about the technique of Remplissage. Do you do Remplissage with Bancard? Do you continue to do, or you do only Latarjet?
I must confess I don't do Remplissage anymore. I've done many at the very beginning because I believe, Eugene Wolf, that it was a good idea. But as soon as I started to do more Latarjet retroscopically, I stopped doing Remplissage. And we published the fact that after Latarjet, even with old patients who were off track before Latarjet, none of them were on track. And I must even confess that I never had any recurrence due to the amount of a bony problem in the heel sacs location. So I'm not a fan of Remplissage, but I believe some people can do this, and I think it's a good technique with association in Bangkok in case of small problem. But I have a big issue regarding Remplissage, if I may ask. Remplissage is okay for me as soon as the heel sac is close to the attachment of the rotator cuff, but sometimes the heel sac is far away from the rotator cuff, and there is a big cartilage distance between the rotator cuff attachment and the heel sac. So I would love to know for the people who are doing Remplissage, how do you manage on this situation where the Remplissage must be done when the heel sac is very far away from the heel sacs?
Okay, it's an interesting. I can show you. I did for this patient a Remplissage on the Bancard, and I have 5 years follow-up, and she's very happy. I was lucky because there is no pain and no external rotation limitation.
Can you comment, Philippe, on why you chose to do Remplissage, although the lesion was off track?
This lesion was on track.
On track.
On track. It's the reason why I didn't do Latarjet. If it was off track, I do Latarjet. But this is on track. This is 36 years old. She's a laser woman, and I decided to do soft tissue procedure. But I was afraid to do Bancard, and I prefer to augment with a Remplissage. But I think that when I do Remplissage, I put my anchors not too medial, but lateral, to avoid the limitation of external rotation. And I think it's very important not to medialize too much the cut. What do you think, AG?
I have a question to you. What is your indication of Remplissage? Because this case is an on-track lesion.
Yes.
So Remplissage is not necessary theoretically. So why did you add Remplissage? What's the indication for you?
Because I did a series of Remplissage of 50 cases a long time ago with 5 years follow-up, and I was very happy. But after 2 years, I have recurrent dislocation for people with off-track. I am agree with you now, but this case is an old case, 5 years ago.
Okay.
It was interesting, but now I agree with you. When there is on-track, I do only Bancard procedure.
Okay, I agree. Thank you.
And what do you do with the bone fragment? You try to repair it, or?
The problem is the first dislocation was 1 year before to do operation, and there was an osteolysis of the bony Bancard, and it's a very small fragment. I think that you can repair the bony Bancard in emergency before three months or 4 months. But if you wait 1 year, there is no bone. What do you think, Emilio?
I think there's a possibility of doing a banker repair, including the bone, and these patients can do well in the long run.
Yes, but after 1 year, there is no bone.
Well, probably the bone can disappear, but the patients remain stable.
Maybe you can. I can show you the second case. I hope so that Laurent, you can follow me. This is the second case. This is a patient of 35 years old, right shoulder, leisure, sedentary, and he did first anterior dislocation in 2008. After 2 more anterior dislocation. He was operated in 2013 with arthroscopic Latarjet in our hospital. And after 6 months, he had anterior subluxation in abduction external rotation, an excellent mobility, complete range of motion. There is no hyperlaxity. And you see that there is a little pain free, and the function of the shoulder was not very well, 40. So this is the X-rays of the bone graft with the 2 screw, and I did a CT scan with 3D reconstruction, and you can talk about the positioning of the bone graft on the direction of the screw, and the reason, maybe I don't know why, the reason of subluxation, but you can see very well the CT scan, and there is a Ilsax lesion. There is a good union of the bone graft with the 2 screw. So the question for the participant is, this is a young man, 35 years old. He would like to do sports. He has pain, and he have anterior subluxation. And what are you doing for him? Do you remove the screw? Do you do a soft tissue procedure, or do you do a bone graft? Okay, Edgy?
Yes, he's 35-year-old male, and he already had the Latarjet procedure.
Yeah.
So before Latarjet, he had an off-track lesion, or
I don't remember.
you don't know?
He was operated by another surgeon, and I received
Okay.
the patient without CT scan.
Okay. And after this Latarjet, he had a subluxation again. So I think based on the CT scan, the coracoid process was placed too medial from the glenoid surface. So it was not so effective. So, and I wonder if he repaired, the first surgeon repaired the capsule or not. If he did not, then I think I should try to repair the capsule. It's a soft tissue repair. It may work, but if this coracoid process positioning was the main cause of instability, then we have to take this coracoid process away and put it in the right position, or we could use Eden-Hibinet procedure, which is an iliac crest bone graft. I think there are various options in this case. But if the anterior capsule is a robust structure which has not been repaired during the Latarjet procedure, then I think that should be tried.
Okay, G, it's good opportunity. You have option. Eden,
a coracoid block and repositioned it?
I think that's one option, but I think it's very difficult to perform. I don't have any experience of that.
You did that, Emilio?
No. I've done that. It's difficult to revise patients with a failed Latarjet. These patients had only subluxations, but I think that when a Latarjet fails, there are 3 potential scenarios. First, that the bone graft is disappeared because of osteolysis or avulsion, and in this condition, a new bone graft needs to be performed with an adhesive net. The other option is that the bone graft is in a bad position, either too superior or too medial. And if this is the case, I try to osteotomize the graft and reposition it closer to the edge of the glenoid. I've done this a few times with good results, I can tell you. And the third option would be in patients where there's no bone defect or the bone graft is in a good position and healed. And this is quite uncommon because these are usually very hyperlax patients with inferior instability. And probably these patients should be managed with a different procedure, like a capsular reinforcement, but these are very uncommon. So probably in this case, I would try to approach it with open surgery, trying to check the position of the graft. And if the position is wrong, I would try to remove the screws, osteotomize the graft, and reposition it in the proper position. And if not, I would do a net.
And so you release the conjoint tendon, you manage to find a plane and...
So it's not easy. I do it in open. I don't do it arthroscopically, but it's not easy. Sometimes it's difficult to find the split of the subscapularis. So what you have to do is to follow the conjoint tendon until you feel with your finger the bone graft. That's the place where you need to see where the axillary nerve is and to identify the bone graft, and that's where the split should be performed.
Okay, Laurent, what do you think about this case?
I think the analysis of the other speakers is very good. And number one, you need to analyze why you had a failure with this patient who is young. And I think that the analysis of AG is very good to say that the coracoid is too medial. The two screws are very oblique and they are absolutely not parallel to the glenoid. So we know in these cases that the forces of compression of the screws is going to lead to medialization of the bone graft, and the more you will compress and the more medialized the bone will be. The subluxation scares me a lot regarding the location of the split of the subscap. And most of the time when you have such a subluxation, it's because the split was not at the correct position, and the patient has a problem of balance. I'm afraid that, unfortunately, solution number one, which is just to go arthroscopically with the soft tissue procedure, may not be enough for the patient. And I'm on the same page as what Emilio is saying to treat the problem of bone, because it's a really bony problem here. Personally, I feel it is very difficult to remove these screws. The screws on this period were screws were very bad metal quality. And when you try to remove them, it's many cases you cannot, because the bone, the screw becomes very soft and it's very hard to remove. This is why new screws has been developed and very important to use instead of the old screws. So removing the screw is sometimes not an option, but adding a bone instead of the previous bone is definitely an option to restore concavity and width of the glenoid. So I would definitely open or arthroscopically according to your preference. I don't think this really matters. I think that we need to restore a large glenoid in order for this young guy to go back to activity. Now, maybe some people who has developed lastly some soft tissue reinforcement with biceps or artificial graft or allograft can even be something added to this reconstruction of the bone. But I think the key of the success of this patient is to reconstruct the bone with some complementary bone graft that can be iliac bone graft, allograft, tibial plateau, whatever you prefer, according to the countries, and every steps of kind of bone graft has a different advantages and disadvantages. I would personally do it, number one, arthroscopically. I would, number two, try to remove the screws, but if I cannot, I would only maybe cut the screw and remove the head. And number 3, I would use a iliac crest bone graft and do an head and data arthroscopically as we published.
Thank you, Laurent. I would like to show you what I did a long time ago, but I am very happy because I did exactly what did you explain, Laurent. But I show you the case. Thank you for the good assessment because it's not so easy. The last problem for the patient is the pain. How do you explain the pain? Do you think that this is a cartilage? Or do you think that this is an impingement with the screw? What do you think, Laurent, regarding the pain?
Think that there is a permanent subluxation on your case. I could not really see very well because the images were small on my screen, but it looks that there is a kind of permanent subluxation, and I'm afraid that the screws did damage a bit the cartilage of the head. And I'm afraid that some soft tissue was not covering the screw, and it was maybe a very bad thing for the humeral head of the patient.
Do you have comments, Emilio or G, regarding the pain?
I have comments. I think that Laurent is completely right. And when the screws are very oblique, as in this case, the reach of impinging with the humeral head is increased. There is a recent publication by Arnaud about the improvement of this patient with painful shoulder after Latarjet, just removing the screws. So probably the pain is related to a screw irritation of the humeral head.
Okay.
Well, but in this case, the coracoid process is very medial, and the head of the screw is also far away from the humeral head. So I don't think there's any impingement in this particular case. So the question is what causes pain? And I read the paper, after removal of the screw, the pain goes away. But what does this screw does in the patient?
You are absolutely right, unless you have a subluxation of the head. And
yes,
when you have a subluxation of the head, then you have an impingement between the posterior head, which goes in abduction, external rotation. You have a subluxation, and then you have an impingement. And when you reduce, and then the subluxation does not happen anymore, and then there is no pain anymore. And most of the time, it's quite interesting to see this patient. And I made a video today of a patient who had no screw. I know you love underbutton, Philippe, and you want to show cases with failure of screws. But despite this, we sometimes have the opposite, and some underbutton with some permanent subluxation. And I think that we may have cases in both techniques of resorption of the graft and with non-union and with permanent subluxation. And I think every time a patient is subluxated anteriorly, is damaging the posterior cartilage of the humeral head.
I think that the analysis of Laurent is excellent because I did a bone graft, iliac wrist bone graft, and I used the technique of suture button fixation. And it was very interesting because it's not very easy to remove the screw, and it was impossible for me to remove the screw. And I decided to add laterally the iliac wrist bone graft on fixation with 2 suture buttons. And it's very nice technique because we don't do dissection of the nerve. We go through the rotator interval. And I think that you can see the X-rays postoperatively. And I show you the X-rays after 4 months. And you see very well that the positioning of the first graft was too medial. And it was possible with the technique of on the button to restore the concavity of the glenoid. And it's very interesting to show you the CT scan after a few years because you have a perfect integration. I show you, I try to stop. You have the integration of the bone. I think that is very interesting. the concavity. This is a result. It's important because the patient is not so happy. You see that there is no recurrence, there is no apprehension, but it's still painful. And I think that the cartilage is a problem of the pain in this patient. And you see that the function of the shoulder is 70%. She is happy because it's stable, but it changed in sports. And I think that Eden was a good way, maybe, but it's not possible to restore a very nice shoulder.
Yeah, may I make a technical question? Did you remove part or abrade it? Did you abrade the former graft, the previous graft?
Yes, yes, it was necessary to abrade a little, but I tried to remove the screw, and I agree with Laurent. It was very difficult. Hello, Marcus.
Hello, Marcus.
Good to see you, friend.
Good to see you.
Strong.
So, Philippe, in this case, you remove the lateral half of the coracoid process to put the crest in.
Yes.
Okay, it's a very smart way.
A little abrasion of but it was possible to remove the screw. And I saw the patient 5 years after this procedure. It was not so happy because he was a little painful. And I think the cartilage was the main etiology of the pain.
And may I ask you a question, Philippe?
Yes.
What is the position where the pain was the most important?
The pain was most important when he did weightlifting. Weightlifting because it does fitness, and when the joint was in constraint, it was painful. It was not unstable, but it was painful when the joint was constrained.
The best advice is tell him stop weightlifting.
Yes.
Maybe the best command would say to be good at the first shot, because we know that revision of shoulder surgery is never as good as what primary surgery could be. But who has no failure can lift his hand. I'm not one of these. So I admit that this is it's a very difficult technique. I think that this is one of the most difficult surgery to perform, and when it's not very well performed arthroscopically, it's better to do it open. And I think that maybe the under button is a plan B solution, but let's wait that follow-up of the under button compared to the screw is as long as what the screw experienced to know what is the long follow-up, and let's see how it works. But I think that even if some people prefer the screw, some people prefer the under button, I think that in the future we may find indication for each of them with different advantages and disadvantages for both of them.
Marcus, did you see the case or no?
I've just seen the final result, Philippe.
Okay.
Sorry.
Did you have because you use a iliac crease bone graft as a primary operation when we do Latarjet, but in this case, the Latarjet was a little medial position, and the patient was a recurrent subluxation. And in your experience, did you do iliac crease bone graft for failure of Latarjet?
Honestly, no. The Latarjets we did, they worked very well, I have to admit. so there was no need to revise them with an iliac crest. But honestly, since we have not these huge numbers of Latarjet in our experience, we don't have these high numbers of revisions. I mean, the ones we looked at our Latarjets who were revised due to pain that was just been discussed, and one potential reason for pain was always the so-called screw problem. But however, when we removed the screws, because we thought that the screws are the problem, in some cases the pain was still there. So in other cases the pain was gone, although the screws were not protruding. So I'm not really sure about this potential problem of pain after Latarjet. that I think is currently not really explained. And honestly, I have seen the same situation with iliac crest. There are some patients who have pain after iliac crest procedure. They have a nice graft healing. It looks perfect. They are stable, but they still have this kind of discomfort pain that you cannot really explain. They're not apprehensive. I mean, you can really do an apprehension sign and this is negative, but they still have this kind of discomfort, and it's hard to explain where it originates from.
Laurent, I have a question for you, Laurent. Do you have indication of iliac crest bone graft primary?
No.
No, never. Okay.
No, we don't have any indication for iliac crest as a primary, and as we published already, we have always been on track after Latarjet, even for patients who were off track. I think that this is I think there is a way to place the bone graft in order not to lose any width of the, and I must say I'm a little bit like Marcus since many years now. We don't have any failure of Latarjet. We have some recurrent instability for past cases, but this last year we don't have any problem. I think we really solved the solution and technique in order to have something very strong and reliable now.
First, Marcus, what is your indication for Latarjet?
We have done indications in the past using Latarjet when we had a failed soft tissue instability repair with, let's say, a minor bone loss. So we decided the first operation didn't work, so we go for Latarjet. But it has changed. I mean, now I'm doing more and more arthroscopic iliac crest with a small little piece of bone, bicortical, arthroscopically without any, screws at all, without any buttons at all, just with sutures. And they seem to work very well. I do agree that the harvesting of the iliac crest is still something that is not solved. But over the last, I would say, 2.5 years, I didn't do a Latarjet anymore. So I go for an anatomical procedure without any metal. And if this fails, which has not been, but it's only 2.5 years now, then I would consider a potential non-anatomical operation. Sorry to say this in a French environment. But I said something positive before, Laurent.
Now, it's this is great about this screen is that we have 6 different positions. And what would interest me is the opinion of AG, who has published about the biomechanic and the importance of the conjoint tendon for stabilization that we provide with Latarjet, which is leading to 130% of stability of a normal shoulder. So do you expect, Marcus, that you will get the same biomechanical effect with a bone graft than what you could obtain with a Latarjet?
No, I think it's clear at time 0 in the lab, the Latarjet is more stable due to the triple locking effect. There is no doubt. I do not question this at all. But obviously, time 0 does not transfer all the time into reality. And if you look at the recurrence rate of the new, let's say, more or less anatomical iliac crest procedures, recurrence rate is not significantly higher compared to Latarjet. So that's the reason why I'm still on the anatomical path, even if I don't have this high primary initial fixation as shown in the lab.
But to answer your previous remark, Marcus, I think that there is no fight between us. I think it's very important that each of us is pushing the envelope as far as they can in such a direction that will, with our experience, help the people in the future to choose between different paths. And you push your path, I push my path, some people else is pushing a different technique. I think we need to be very honest and to report our results with the real complication rate and not to hide the bad result. And once we do this, maybe we contribute a little bit on the evolution of science and treatment, fair treatment for the patients.
I think, we always have to think about also not just personal experience or single surgeon experience, but looking at prospective trials, potentially not randomized, but prospective trials that compared these two fixation methods or reconstructive methods. And there is one by Philippe Moroder with an open Latarjet comparing the one with the Resch, the J graft operation. And from a clinical point of view, let's say, talking about stability, there is no difference. So both techniques works, that's for sure. There is less, let's say, there's a little bit of a problem with internal rotation in these Latarjet groups, what they have shown. But, you know, this is obviously not the procedures that you and me are doing. We're doing these things arthroscopically. So I think the future really should be to have a couple of groups of surgeons, what you did with the French Society, where comparing these anatomical arthroscopic new techniques with the arthroscopic Latarjet to see where the problems are really, because obviously we are moving in the arthroscopic direction, that's for sure. I mean, there is no doubt, either with the Latarjet or with the iliac crest. So the future should be to sit together and look at these two methods in a prospective manner.
Yeah, if I may say, Philippe, I don't want to be too long, and I want you to expose the three cases. But yes. Can I just give one very short remark?
Yes.
Okay. I think that it's very important to think that the future is pushing to arthroscopic technique. It's true. But I think that today, sometimes it's important to be able to convert to open surgery at any stage and not to be the one who really want to end up arthroscopically, whatever the result is. I think that it's the opposite. The result should be good, and converting from arthroscopic to open technique at any stage of the surgery is not a shame. And I think the shame is to get a bad result because we want to push too much the arthroscopic technique. So I think that open Latarjet is certainly better if it's a good open Latarjet than a bad arthroscopic Latarjet, whatever the technique is.
Yes, everybody is agree with you. It's not a challenge. The goal is to obtain a good result. It's not a challenge for the surgeon.
Maybe the beginning can be arthroscopic and the end can be open, and you can switch at any stage.
No problem. Jean-David will present the last case.
So I'll try to go quickly because we don't have a lot of time, so I'll skip the beginning of the case. But it's a 20 years old that was seen initially by Philippe Hardy. He had the first dislocation in 2012, and we saw him for the first time in 2015. He has had an arthroscopic Bankart repair and then a Latarjet because this failed, and the Latarjet was done with the tenotomy of the subscap. Now he feels very unstable. The range of motion is quite good except in internal rotation, and when we examine him, it looks clearly that his subscap is not functioning very well. No pain, a very low functional score, and a very low row score. And this is his X-ray. So maybe you want to comment on the X-ray quickly? Maybe Emilio, if you see something?
Well, I see there is two procedures. One is a soft tissue procedure, and there are some anchors, metallic anchors. And there is also a bony procedure that was the Latarjet with two screws. With two screws, I don't see very well the axillary view. Or the Bernard-Joe view?
There was just one screw actually, but the
screw, one screw which is bent.
Yeah. Yes, probably.
Which is bent.
And so here is, for me it looked quite low, the quite inferior, but
yeah, it seems that the head of the screw is out of the bone and is probably impinging and damaging the subscapularis. Am I right?
Well, this is his arthro-CT. I'm going to move a little bit quickly. So there's a small Hill-Sachs lesion you can see. You can see the anchor of the Bankart repair. And this is where we would expect the Latarjet to be, but it's even lower. But it's healed. It looks a little bit lateral, but because it is so inferior, it's not that big of a problem, I think. But it is very inferior. Here are the sagittal views. Okay. Now, if we go back to the axial views, because we were paying attention to the bone, but not that much to the soft tissue. But if you look at the subscap, I think the lesser tuberosity. He looks completely naked. There's nothing, and I think the subscap is completely torn. But if we look at the soft tissue, the muscle does not look too bad. So I was going to ask you what you would have done at this stage, but this patient was operated on by Philippe Hardy. And so this is what he did. So I'm going to move on to the next step. He did a subscap repair using triceps tendon allograft because he felt that the muscle was good and he wanted to try and repair that subscap. He felt that the bone block was not that bad. And so he decided at the same time to retighten the capsule and to fix the capsule on both the glenoid and the humerus to do like a sling with the anterior capsule. And so I saw this patient 2 years ago with not too bad active range of motion, but again, limited internal rotation and same bad subscapularis on clinical exam. And he still felt very unstable and he kept dislocating every day. No pain at all, but he was very miserable because when I asked him the function of his shoulder, he said 1%, and the raw score was very low also. And so this is the CT arthrogram at that time. So you can see it's basically the same, except that now you have much more metal. And the subscap is not healed. And I don't have the soft tissue for this one. But it's basically the same thing, except that now the muscle does not look great, so I don't think it's repairable at all. And so what would you have done at this stage for this unstable patient with no subscap?
Emilio, what do you think about that?
I think that the reconstruction of the subscapularis was already attempted, and I can tell you honestly, I would have tried the same that Philippe tried, but I would have probably have failed as he did. So I think that now, in spite of there's no subluxation, I think this is a good indication for tendon transfer. It's the only option, trying to do a latissimus dorsi transfer to restore the function of the subscapularis. I don't see any other alternative, but you are much more experienced than me in that kind of procedures.
And would you do anything with the bone because the Latarjet seems so inferior?
Yeah, I think that the problem is that it's too inferior, and probably it seems like it's too proud. It's unusually proud. I don't know what the position, the original position of the graft was, but I will probably try to osteotomize the graft and to reattach it to the anterior glenoid rim in order to decrease the volume of the graft.
Hey, G, what do you think about repair the subscapularis?
Well, I think you already tried once to repair the subscap and it failed again. And the main reason of this failure is the prominent bony block plus screws. So I think I agree with Emilio. We need to cut the tip of the coracoid process and remove the head of the screw, or if it is possible, remove the screw as it is. And then I think we can use the pec measure transfer to fill this subscap deficiency. I read a paper, I don't have any experience by myself, but I read a paper they performed Edenhibinet plus pec measure transfer for the failed Latarjet with a failed subscap. So,
but are you not worried that the pec major is going to pull in the front the humeral head as it's already unstable?
That is possible.
Arthrodesis?
Yes, he's very young, 20 years. So
25
he's very unstable, very unhappy. I think the very secure way is the arthrodesis, if he accepts.
I have looked in the literature and it's absolutely not published at all, but does any one of you have experience of a reverse shoulder arthroplasty instead of an arthrodesis in these very unstable patients that have a good functioning deltoid? Maybe to have a constrained joint could be a solution?
I don't have any experience.
Laurent,
Yes.
do you have an experience regarding Eden-Ibinet failure with irreparable subscapularis?
With irreparable what?
Subscapularis.
Latarjet failure.
With no subscapularis.
No. If the patient already had a Latarjet and an Eden-Ibinet and then recurrent, I just have one patient who had a LR dans l'os and who had a LR dans l'os, Eden-Ibinet, no subscap, and a previous Latarjet, and she had anterior and posterior dislocation bad, and she even had she's riding horses, and she even had a hip dislocation and ankle dislocation in a real LR dans l'os. Okay, I did a double bone graft, iliac crest, anterior and posterior, one shot, arthroscopically with the screws going like this, with a double bone graft, restoring a quite of hip, and amazingly, that was not as difficult as what you can imagine, because in LR dans l'os, the joint is very lax and there is a lot of room, and it's very impressive at the X-ray, but it was not as difficult as what could be a stiff shoulder, for difficult cases here. It was very lax, so I had a lot of room to operate, and I could put these two bone grafts. I would not say it was an easy procedure and not scaring, but I did it. And I even did it on the other shoulder 1 year later, because she even had multidirectional instability and everything on the other shoulder. The first shoulder was a success. She had no more dislocation. And on the other shoulder, she had one recurrent dislocation on the top of the posterior bone block, who got partially resolved. But yes, I have some experience of recurrent Eden-Ibinet, and it can work. And I would say that for this young lady, before going to an arthrodesis, I did not hear all the presentation, but I understood by your last minute conversation. I think I would do a bone graft again with an iliac crest arthroscopically.
Okay, Jean-David, can you show us the screen? Yeah. The results the techniques that you use?
So that was we did the deltopectoral approach, and there was no more subscap, as you can see here. And the bone block was not too high, but it was very low because I did not remove anything, and the bone block is under that tissue here. So it's very inferior, and I don't think it was very useful. So we decided to do an iliac crest bone graft here, and then we took the latissimus dorsi, and you can see the iliac crest bone graft that is screwed here. And we put the latissimus dorsi all the way on the humeral head. And so it's really not perfect at all. The patient is very happy because he was so miserable before, but the subscap is still not working. So I think it's more of a tenodesis effect that pulls the head posteriorly, or it's because it restores some soft tissue anteriorly. But he still has a lift-off test and a positive bear hug and the belly press. But now he has a normal life. He goes to the gym. He has had no recurrence yet, and he feels better, and he still has no pain.
Jean-David, I just by chance saw one of my patients that I operate on, and that was 4 years ago during anesthesia life surgery. It was latissimus dorsi transfer in 2017. We did it 2017. We did it together with Bassem El Assam arthroscopically, and amazingly, the result was initially a tenodesis effect, and now is very effective actively. And I wonder if your patient may change with time, as he is very young, maybe to an active and better function with time. And I think that you should not throw away the fact that maybe the transfer will work better with time. As Marcus was saying before, sometimes you have biomechanic, but sometimes you have biology and mechanic. And sometimes biology and God helps us a lot to make the things working better with time. So congratulations for your case. It's a very interesting case.
Yeah.
Very well done, and it's certainly a very good indication.
I think that another comments regarding this case, because do you remember a long time ago about the shrinkage procedure?
Terrible.
It was terrible. And I remember that sometimes you have no capsule and you have a lesion of the subscapularis. And I did 2 cases like that. I did augmentation of the subscapularis with the latissimus dorsi, and the patient was stable and was very happy. I think that tendon transfer on instability, anterior instability, is sometimes useful, and we have to think for this indication. And thank you, Jean-David, for this case.
You know, amazingly, Jean-David, I had a look a little bit before this at the literature regarding the very complicated case. And what I even saw is that for some anterior recurrent instability with irreparable subscap, there is in the literature some people who did a pec major transfer.
Yeah, it's Tiger Lee from Boston.
With good results.
It's one case.
Yeah, I
Two
know.
cases.
I know, but your case is one case only.
Yeah.
And so we should not blame the other people, you know. I think that amazingly the tendon transfer are sometimes working in a way that we don't really understand. And I have one of the patients I remember very well who came to my office in Switzerland. And she came to me with a failed Latarjet, a failed even Binet, and I wanted to make a lat dorsi transfer, and she refused. And she went to Zurich, and she had a pec major transfer. And I know this lady because I see her in different opportunity occasion, and she's doing very well with a pec major transfer behind the coracoid process for anterior instability and subscap failure. So
it's 2 cases.
that's 2 against 1.
Okay, I'd like to thank you a lot because it's not so easy to exchange sometime with the internet. But I think that it's the first experience that to do a shoulder board live. And we try to do again, we try to increase the technical problems. And we try to answer to many questions from the attendees. And it's important that to know that you can see on replay this first shoulder board. And thank you very much, Edgy. Thank you very much, Emilio and Laurent. It was a very great pleasure to spend time with you. And I hope so that for the young surgeon, it's education and maybe questions and to see that it's not so easy as stability. And sometimes you have to do tendon transfer combined.
No, thanks to Jean-David and you, Philippe, to invite us to come to this. And thanks for making this happening. And I think it's very important for education to try to do the best we can do with the pandemic. So thanks to all of you, Philippe and Jean-David, to start to this kind of process, and hope to see everybody safe, to see you in Berlin with the next Congress of Marcus. Marcus is certainly kick off from the airport because there's not enough people, and but we know Berlin is going to come, and you will have your meeting, Philippe, and I think that we will hopefully do again the meeting of Annecy Life Surgery in October, and we hope to be back to normal situation. All of us are trying to manage the situation, and as long as everybody remains healthy, and we will keep on going forward and moving the word forward like this. Thank you, Philippe.
Thank you. Thank you. Bye-bye.
Bye-bye.
Thank you very much.
Bye-bye. Thank you very much.